Hello and welcome to this Health Foundation webinar on the future of the NHS. What do the public think? My name's Ruth Thorby. I work in the policy team here at the Foundation, and I'm going to chair this session with our expert panelists and you, the audience. So thanks so much for coming along. The topic today, as some of you might have heard, we're having a general election on the 4th of July. We know the NHS has been amongst the top 3 concerns for voters for at least the last year, and it will be a huge issue in the next 6 weeks of campaigning. We can expect to hear many promises to reform and improve the NHS from all parties over the next few weeks, and a new government will have to design policies to change and address the multiple challenges that face the NHS. We need more staff, better buildings and equipment, more prevention of ill health, shorter waiting times. But will these chime with what the public thinks the problems are and what they think the NHS needs in the future? Since 2021, we've been working with Ipsos to run a series of polls with the public on how they view the NHS. And it's been striking to see how low confidence has dropped in such an essential public service, but also how wedded people are to the fundamentals of the NHS model, tax-funded, free at the point of use. Last autumn, we decided to probe behind the polling, running workshops with people in 3 cities over 2 days to find out more what people really think when they're presented with more information, more choices about options and time to think. And that's what we're going to be hearing about today. I'm really pleased to introduce our 3 guests. We have Kate Duxbury, who's the research director at Ipsos, has nearly 2 decades of research on public perceptions, who'll be telling us more about the work we did with the public. Tim Gardner, Assistant Director of the Policy Team here, who's led on the work and previously worked in the Department of Health and Social Care to help us make sense of it all. And Richard Sloggett, Founder and Programme Director of Future Health, a research organisation that works on economy, technology and prevention, who was also Special Advisor to the Secretary of State for Health and Social Care in 2018 and 19. And I have to say, we're sorry that Louise Ansari, the Chief Executive of Healthwatch, can't be with us today, so apologies about that. So how this webinar will run is, first, we're going to show you a short film to give you a flavour of what people told us. Kate will then give us a presentation for about 10-15 minutes of how we did the research, what we asked people and what they told us. Tim will then give us some reflections on the implications of what we heard, and then we will have further thoughts from Richard, and then we'll open it up for discussion and questions and comments from you. Final bit of housekeeping before we kick off. This webinar is being recorded and it will be up on the website in the next 24 hours, and a subtitled version will be available soon after that. We will be taking questions throughout the webinar. Please put these in the Q&A box, and you can upvote with a thumbs icon those questions you like and want to see answered. I'm going to do my best to group these up into themes. I would say we've got a lot of people watching today, which is great, but we may miss the odd question, but we'll do our best. So I think we might as well get going. So we're going to see first a short film about what we learned.
As an independent charity, the Health Foundation wants the big decisions about the future of the NHS to be based on the best available evidence, and that includes what matters to the public.
Fundamentally, it's the best model that you can possibly think of. There will be aspects or issues which are not working at this point of time and definitely needs improvement. But will I want to replace this with something else? I don't think so. I think what we need to think about is how do you improve what you have today?
We know that the NHS has worked very well. We've been one of the best healthcare systems in the world for an awful long time. And it feels that we've got a puncture in the tyre and we don't need to redesign the tyre, we just need to repair it and keep on going.
I think primary care should be paramount, because I think if you can try and nip things in the bud and try and get things sorted at the first end, then you wouldn't get all this backlog going on and all the overcrowding in hospitals.
We need to strengthen the primary care, and once we get at par with the current hospital care, then the funding should probably split, because obviously we still need the hospital care.
Have a massive drive on community care, on GPs, on care in the community. I think if they did that, it would be a vote winner.
We need to just get taxed more, and for the next 10 years, hopefully it'll get better. But we do need reassurance that this is going to go to the NHS and it will improve by this day, and, you know, seeing it actually happen.
If I knew it was going directly to the NHS, I wouldn't mind paying £20 a week or whatever the number, I wouldn't mind.
Before more funds are injected into the system, I think a review of how those funds are spent is necessary.
Any business, you have a 5-10 year plan. So regardless of governments coming and change, they've got an objective what they're trying to do, rather than having different governments come in and each government has their own policy and views.
The trouble is we have inconsistent governments, we have inconsistent cabinets, and we need much more consistency. So in a way, I think that the whole business of running the NHS should be removed from government.
I think I would have more confidence in the government's planning for the NHS if they were to provide a baseline of finances that was access for the NHS, so they could plan long term for their financial future.
Our big hope for this work is that it's going to really help to shape the decisions that policymakers make over the coming few years.
Thank you. I hope that gives you a bit of a flavour of what those days were like. We're going to hear more now from Kate Duxbury, who's going to talk us through a bit about what this research is and how it works, and also what we learned from it. So over to you, Kate.
Thank you, Ruth. And thanks everybody for joining us today. It's lovely to watch the film. It's like seeing old friends because we spent such a long time with each of our participants. I just wanted to start off by talking a little bit about deliberative research for those who are less familiar with it. This is a qualitative research technique that works brilliantly when you've got topics or challenges where there's genuinely no right or wrong answer. There's value-based judgments involved. So, for example, it might be ethical questions, or it might be issues where there are very complex trade-offs. And in doing this research, we spend a large amount of time with participants. We challenge them on their thinking. It's a combination of feeding in information to them, balanced information, which they then take away to discuss with other participants, and they listen to each other's perspectives for people that have different experiences and different backgrounds to their own. The first question we deliberated with participants in this project was based within the current constraints on the NHS. So the question was, with limited resources, we face a choice about where to focus and the balance between primary and community care or hospital care. What do you think the focus for improvements in the NHS should be? We did find there was a strong leaning towards a greater focus on primary and community care rather than hospital care than there is at the moment. So on the next slide, in the picture you can see here, we asked people to line up in the room to show us the continuum of where they thought the focus for improvement should be. And the gentleman on the right-hand side here wanted the focus to be on hospital care. The people on the left-hand side wanted the focus to be on primary and community care. You can see a chair about 2/3 of the way across to the right-hand side. That represents the current balance being towards hospital care. And you can see participants have mostly clustered to the left of that chair, and they wanted a greater focus on primary and community care than there is at the moment. Now, by this point, we had already given them some information, and we'd presented to them that the balance was already towards hospital care in terms of the amount of funding, but also importantly that increases in funding and increases in staffing levels had been higher in hospital care than in the primary and community sector in recent years. Having said that, we also asked a question in our polling where survey participants had no information at all. And in this, we also found a leaning towards primary and community care. So on the next slide, you can see that 60% of the public think the government should prioritise making it easier for people to access community-based services like GPs, NHS dentists, compared with 29% who think the government should prioritise making it easier for people to access care in hospitals, including, for example, A&E and planned procedures. And the deliberative research on the next slide gives us the reasons that participants leaned towards primary and community care. Now, we spoke about this for hours, there's plenty more detail in the report. The key point, though, participants were aware of the interdependencies between different services in the NHS, and they were really keen to diagnose the root causes of high demand and address them at the root, which they thought overall would be a more efficient approach to the NHS. So if you click on Chloe, the first part of that is they thought a focus on primary and community care would reduce demand for hospital services. This was partly about keeping people healthier, it was partly about early diagnosis and about earlier intervention in people's conditions, meaning that they might not need, their condition might not escalate and they may not need further input later. They also, on the next click, thought that better access to primary and community care would mean that patients wouldn't end up in hospital and they wouldn't end up in A&E or be staying in hospitals for so long, and therefore overall demand for hospital care would reduce. It's worth saying that wasn't universal on the next slide, so a few participants leaned towards hospital care from the outset, and that was mostly because they thought people who need hospital care have got the most acute needs, and therefore that is where the focus should be. And once we'd discussed this topic in detail for a couple of hours, there was also some movement towards hospital care. So if you think back to that image of where people were stood in the room, any movement was towards a focus on hospital care. Overall, though, we found that participants continued to favour a greater focus on primary and community care than there is at the moment. Having said that, on the next slide, they did find this trade-off very challenging to stay within the current restraints and not be able to just put more into the NHS. And there was a feeling that even if they do prioritise a greater focus on primary and community care, that they wouldn't accept a reduction in the access to or quality of hospital care. We move participants on then to talk about the trade-off between the level of funding that the NHS has and the service levels it can deliver. Now, our polling shows that around 8 in 10 of the public think that the NHS needs more funding, but it's fairly easy to say that in a survey when you don't need to think about where that funding is going to come from. So in the deliberative research, we really wanted to challenge participants on this by showing them the amount of money that would be needed and also what that might mean for them personally, so that we could understand what impact that might have on their views of NHS funding. And overall, we found that participants generally wanted the NHS to deliver better services than it is at the moment, and therefore said they were willing to pay additional tax in order to achieve that. Now, the cost of living crisis, it really loomed large throughout these discussions. On the next slide, it caused most participants to at least hesitate about saying that taxes should increase. And that meant they wanted government to do everything it possibly could to minimise increases to taxes and do everything it could before resorting to raising taxes. And for some participants, actually, they could never overcome these concerns about cost of living, and they continue to hold a view that funding levels should not be increased and accepted that that would mean service levels stay as they are at the moment. Ultimately, though, many participants thought current service levels were not acceptable, and they backed higher funding via taxes to improve the NHS and make sure that it stays accessible to everybody. That is not to say that they were willing to write a blank cheque for the NHS. Any additional funding raised via taxes came with strong expectations attached to it. So firstly, participants strongly believed that the NHS needs to be more efficient. And one of the phrases they quite often used was as a leaky bucket. So they thought that the NHS needs to be more efficient before additional funding goes into it. And that's one of those changes that participants felt quite strongly would be able to minimise the extra funding that the NHS needs. Secondly, they would need to see improvements in service levels if they were paying more towards the NHS. And then thirdly, they wanted greater transparency and better long-term planning for the NHS to reassure them about how well that money that they were putting in would be used. We also deliberated on the next slide with the public on the current NHS model. So we talked about its pros and its cons, and then we introduced two alternatives. Firstly, the current model, but with additional charges for things like GP appointments and A&E visits. And secondly, a social health insurance system. It's worth noting this was towards the end of the weekend, so we'd already spent a lot of time talking about the NHS and its challenges and its funding. But even despite those discussions, there remained a very strong affiliation with the NHS model, which is in line with our polling, which shows the same. So once we talked about each model, we asked participants to vote on their preferred one. And on this slide, you can see the current model on the left-hand side. You've got the current model with additional user charges in the middle. And then on the right-hand side, the social health insurance model. The blue dots represent participants' preferred model. So you can see that the current NHS model on the left-hand side was by far the most preferred. The red dots show where participants thought the model definitely wasn't right for the UK. And the yellow is where people were perhaps a bit unsure. So either they weren't sure or they needed more information about it. So you can see from that whilst the current model is most preferred, the current model with additional charges is least preferred. And the social health insurance model is somewhere in the middle, albeit with far fewer blue dots than the current model. And the support for that current model was firmly linked back to the founding principles on the next slide. In particular, it being available to everyone when they need it and being free at the point of use. And another strong theme that we saw when comparing it with other models was that the NHS is not profit-making. Any models that included some element of profit-making did worry participants. And we just found there's still just such pride in the concept of the NHS, even though some participants did question how sustainable those principles are and the extent to which they even still apply today. Overall, though, we're not talking about people wanting radical reform. They think change is needed, but change within the current system. One of the main disadvantages that our participants raised about the current model was the level of political involvement in the NHS. And that was something that came up at the very beginning of the weekend. So on the next slide, from the very outset of the discussions, we found that confidence in planning for the future of the NHS was low, and that was often linked with politics. So, for example, they talked about electoral cycles and reshuffles, meaning that politicians take a short-term view, and they also question the extent to which decisions are evidence-based. We put 4 different options to them as possible approaches that would build their confidence that governments are planning well for the future of the NHS, noting that we were talking about governments in general here rather than the current government. And of those options, they thought the NHS being independent from government and long-term planning via an independent commission or review would most build their confidence, in comparison with either a large public engagement exercise or greater devolution to local areas. So on the independence, participants thought that could lead to a more stable and consistent long-term planning that's less susceptible to the volatility of politics and political cycles. And then on long-term planning via a commission or review, again, the independence really appealed to participants, and they thought that that would offer a more stable direction for the NHS, also based on expert input. Okay, so just to quickly summarise our finding on the key deliberation questions. Firstly, we found a focus on primary and community care over hospital care. Secondly, we found there's a desire for improved services, which meant participants said they're willing to pay more taxes, albeit that comes with certain conditions. And then thirdly, we found there was a perception, a real view that we should retain the current NHS model, but with independence from government and better long-term planning in order to build their confidence in its future. As well as those deliberation questions, though, there were other findings that emerged throughout the deliberations, no matter what we were talking about. The first one of those, there's a very pervasive lack of trust at the moment in government and in politics. Now, to some extent, it always has been thus, but that feels more acute right now. One of the words that came up over and over was transparency. So people really have a desire for greater openness and honesty because of this lack of trust. Secondly, We know from our polling that staff are a real priority for the public, and that consistently emerged in the deliberations as well. So participants worried about the pressure on frontline staff, they worried about their morale, the impact that has on retention, and also concerns that the NHS professions just aren't appealing anymore for new generations. And they directly linked that to worries about their own care, such as poor access or feeling rushed when talking to healthcare professionals. And the deliberative research suggests that without evidence of those issues being addressed, it would be very difficult to build confidence in the future of the NHS. And finally, we found there was just such a strong view that the NHS should improve how it uses its resources. And there were countless examples of this raised, from things that people had personally experienced through to what they'd heard about. And that ranged from examples of inefficiency, like perhaps a letter about an appointment arriving the day after the appointment date, through to things like reducing the use of agency staff, through to improving how resources are organised in the NHS, like improved prevention and earlier diagnosis and treatment in order to reduce demand. So that highlights some of the findings. I'm going to hand over to Tim now, I think, to talk about the implications.
Before you do, Kate, actually, there have been a lot of questions while you've been talking. That's a really lovely presentation, but quite a lot of people are asking about how you selected the people and whether they're representative. And then there's some questions about also, did people have experience? Were they on waiting lists? How did we think about what their relationship with the NHS now is? And I think you did some screening on that. So maybe talk just for a few moments, because there's been a lot of questions on it. People are curious.
Okay, thanks, Ruth. So in order to recruit, we use a recruitment agency, and we give them effectively instructions of the type of people that we want to include in the research. And that includes making sure we have a mix of people by demographics. So, for example, different genders, age, ethnicity, different social grades. But we also wanted to make sure we had a range of different views in the room. So we included people with differing levels of satisfaction with the NHS. And we included some people who thought that the NHS is a great project and we must maintain it at all costs, as well as including some people who thought we can't maintain the NHS any further. So we're making sure we've got different attitudes in the room. We also had people with differing levels of use of NHS services. So they're using different numbers of services, different frequency of use. And then in the rooms, when we put people into groups, we try and mix those people up. And the idea is that they're talking to people who they wouldn't normally meet in their social lives, and they're hearing different perspectives, and they're hearing from people with different backgrounds to help them think about things from different viewpoints while they're working together to find the answers to these questions that we put to them. Very difficult questions.
Thanks, fantastic. I hope that's answered some of the questions. So over to you, Tim, for thinking about some of the implications of what we learned.
Thanks, Ruth. Our regular surveys with Ipsos consistently find that people want a better NHS, not radical change towards a different health system. And at a time when we often have to think about polarisation, this sort of breadth and depth of public support for the NHS can be a really important building block in creating a stronger, more resilient service. But we also know there aren't any quick or easy solutions. Before the pandemic, there was a decade of low spending growth and sometimes a focus on short-term pressures at the expense of long-term investment, leaving staffing gaps, crumbling buildings, and outdated equipment. And if we look beyond the NHS, the state of the public sector and the public finances means whoever forms the next government from 5th of July onwards is going to face some very tough decisions. So the beauty of this deliberative research is that it allowed us to engage people in some of those decisions and see what they think, what's important to them. So what should policymakers take from our results? And it's probably worth saying, because I think it's come up in the chat, that we did this research last autumn. We have shared our findings already with a range of policy and political stakeholders who've been very interested. So implications. So in our report, we identified 7 things. So firstly, being more open about the problems that the NHS faces. As I think I may have said, when people came into the workshops, they started out with a relatively nuanced understanding of the issues facing the health service. We then gave them a short presentation on the growing need for healthcare on the one hand, and then also the main factors that will constrain the NHS's ability to meet those needs. Now, this wasn't anything especially novel or dramatic. It was drawing on published Health Foundation analysis and official statistics. If you want to see the slides that we used, all the stimulus materials are available on the website. But people were still visibly shocked to get that information. They appreciated getting a frank assessment, though. So being more open, it's unlikely to boost confidence in the short term. It may even make it decline further, but it might help to build support for the longer term recovery process that is almost certainly going to be needed. Secondly, prioritize community care, primary care and community health services. We know from our work looking at changing population health needs that the majority of those needs, so more people living with major illness like chronic pain, type 2 diabetes, anxiety and depression, it's going to rely on primary care and community services. But political priorities on the NHS so often resort to hospital waiting lists. So it's worth remembering that the majority of our interactions with the health service happen in the community. To put some numbers on it, in a typical year, 25 million A&E visits, 14 million ambulance calls, about 20 million additions to the waiting list, but 350 million appointments in general practice, over 100 million contacts in community health services, over 30 million courses of NHS dental treatment. While people at our workshops were really clear they didn't want hospital services to be cut, they did indicate that they could support a commitment to give primary care and community health services a growing share of the budget over time, which is obviously easier to do if the budget is growing to some degree. Our third point is, and linked to that, is policymakers should not underestimate the public support for investing more in the health service, even if that does mean higher taxes. The polling consistently finds support for increasing the NHS budget, even if that does mean taxes have to go up. That's really easy to say in a survey where people don't necessarily have to confront the consequences. Might think that it's other people paying more taxes or someone else. So in the workshop, we were able to confront people with what this might mean for people in different circumstances who might be a bit like them. And that went down to giving them illustrations of how much extra tax might need to be paid in different situations, giving people the pros and cons of different options for raising revenue. As Kate said, this really did give people pause for thought. But most ultimately still said they would support more investment in a better NHS, albeit with conditions around transparency, making sure the money actually gets to the NHS, and really wanting to have some sort of guarantee that improvement would eventually result. Fourth, we think we probably need to have a better conversation about waste. The discussion, this came up throughout the workshops, but especially when we had discussions about whether or not to increase taxes, often sparked conversations about, well, can't we just make better use of existing budgets? People gave a really rich set of examples about what they saw as waste. Often these were failures of administration or communication, delays caused by poor quality equipment, or problems retaining experienced staff. But very often these were more about things that would improve their experience and their perception of the health service rather than saving money. And in some cases, they would actually probably cost money to bring about. Now, this is happening it's quite a world away from some of the policy conversations that happen about productivity and efficiency. So probably an area for further public engagement that would really benefit from that. Fifth, improve support for NHS staff. I mean, this regularly features among the public's very top priorities for the NHS in our polling. It was another theme that came up throughout the workshops that we held. Any plan to improve the health service really does need to start with improving support for NHS staff. Improving morale and retention could help to positively shape public perceptions of how well the NHS is performing, as well as being the right thing to do. It's always worth bearing in mind that, the NHS employs about 1.5 million people, when they're exhausted, demoralized and burnt out, people notice, and they do wonder what this means for the quality of the care that they're getting. Sixth, we think there's urgent action needed to try and improve public trust. Our polling suggests that only 9% of people in England think the current government has the right policies for the NHS. That's historically low. But there was also quite a wider cynicism around politics and government more generally that came through in the workshops. So this isn't going to be solved simply by having a general election. It's not going to be an easy problem for anyone to solve. But what our findings suggest is that making more use of independent experts, providing more transparency, better use of evidence in making longer term decisions could all help. And there might also be a case of for revisiting the relationship between government and the NHS, as this is what people felt would help the NHS focus on what was right for the longer term future. And then finally, we've heard in recent years, we've heard lots of calls for radical change, some of which would probably see a move away from some of the NHS's founding principles. Now, these ideas, they're really hard to poll people about, and so the real strength of the deliberative method was that we could engage people in them. We could explain some of these notions. We could give them more information. We could give them a balance of pros and cons, and then engage them in a discussion about what they thought of them. They largely failed to resonate with people who were very keen on the existing model of a service that is free at point of use, funded from tax, and available to everyone. So I think rule out radical change, but equally we can't go on as we are and expect different results. So we think the only credible alternative is a renewed, sustained effort to strengthen and rebuild the health service, accepting that's going to take time and investment. But there is the potential there. There is, I think, a window with the public to bring that about. Thank you.
Thanks so much, Tim. Before I turn to Richard, there's been several people asking rightly about the scope of this, and that we didn't talk about social care, and we weren't able to include some of the wider determinants of health. So maybe could you just explain for a minute how we came to put, in a sense, boundaries around the work that we did on this?
Sure. So we had to draw boundaries somewhere. These workshops we spent whole weekends with people, and they were pretty full-on experiences at the time. So we managed to cover a lot of ground, but we weren't able to cover everything. Now, what we did try and do is at the outset of the weekend is we tried to highlight some of those broader connections between the health service and social care, the wider determinants of health. In some of the opening presentations that we gave people, we highlighted those links, and they came up at various points throughout discussion. We did talk a bit when we were talking about changing health needs and what that means for healthcare demand. We did talk a bit about the wider determinants of health. So we made sure that people were absolutely clear that healthcare is not the only thing that shapes our health. We also talked a bit about inequalities in how people access, experience, and healthcare, and the outcomes they get from that, which I think people found in some cases quite arresting and alarming in a few of those cases. So that's broadly where we were. I think we would have liked to cover some of those areas, but that might have to be one for future work.
Thanks, Tim. Really helpful. I'd like to ask Richard for a few reflections on what you've heard. Are you surprised by any of this?
So Ruth, I'm not surprised, I would say, by any of this, but I found reading the report absolutely fascinating, and the nature of the research obviously is very, very topical. And congratulations to the Health Foundation for putting on a webinar the day after the Prime Minister announces we're going to have a general election. Clearly, you're more in the lead than many of the Westminster lobby journalists who were following it yesterday. So, and obviously this research is incredibly timely. Couple of things that I just wanted to sort of put in the mix, given where we are now with this election period, because people, I'm sure, will be quite keen to understand how the NHS, I'm sure Kate in particular will have, experience and views on how this plays out. How is the NHS and Help to Make going to play out in the next few weeks as we roll up towards July the 4th. And there's a school of thought, obviously, that the NHS is one of the number one or number two issue that the public usually talks about. In most polls, it's either the cost of living economy or the NHS. Most elections are won or lost on one of those two issues. In this case, I don't think that's going to change, but what I would say is I don't see either party necessarily wanting to talk up their health, the NHS in a huge way, given the state of the service as it currently sits and the fiscal constraints in which they find themselves. So if you think about the existing administration, I don't think there's going to be many people, Conservative strategists, sitting there saying we need to lean in heavily on the NHS and health, given the record that they have. And that would actually be quite a contrast, of course, with 2019, where we had the December election in 2019. And actually what we saw there was, surprisingly, Boris Johnson and others very much talking up the investments that were going to happen. We remember them well because they've been embedded with us. It was 40 new hospitals, 50,000 more nurses, 6,000 more GPs. So that strategy will shift quite significantly. On the Labour side, what they'll want is they'll want the association with the NHS. They'll want the Labour founded it back in 1948. It's safer in our hands. They'll want the signal, but they won't necessarily want to go into the substance of what they will ultimately have to do, because as Tim and Kate have set out and and everyone can see, this is a system under serious amounts of pressure where there are some very, very tough choices that need to be made. And Rachel Reeves has made it very clear that tax rises are not necessarily on the agenda immediately, and that creates a sort of quite tight fiscal envelope. So on the one hand, the NHS will be an important issue for voters, and it will be something that will be discussed. On the other hand, I expect the politicians to probably try and skate over and around it as much as possible based on those two positions in which we find ourselves in. I think the real question then, and that will also play out through the manifestos as well. So if you go back to the two most recent elections in 2019 and 2017, the sort of legacy of those at the narrative high level is don't be too specific on your policy commitments, because they can come back to bite you, or they can even bite you in the campaign. I'm thinking particularly of the 2017 social care plan from the Conservatives, which basically, quite quickly overnight eroded their poll lead. And if you look at what Keir Starmer and his team, led by Morgan McSweeney, is very much doing, it's a safety first approach. So I expect Labour has set out a health mission. It's got some commitments in it, but it is quite high level. It is fiscally constrained. So from the next few weeks, manifesto publications and other things, I don't expect to see huge new movements on the party's positions. What that then translates into is whoever takes over on July the 5th, and obviously all the polls are indicating it will be Labour. There will be some quite difficult models in terms of how they set themselves up. And I think some of the feedback that comes from the polling here is very, very interesting. So when sort of Kate, you took us through the kind of please get politicians out of the health service, I sort of smiled, because obviously there was a politician who said we should do that, and his name was Andrew Lansley, and created a independent, supposedly NHS England. And there's a whole range of reasons why that didn't work. But politicians need to be in and around the top of the health service. We can't just take them out. I think what we need to try and do, though, is find a way to have them in the system in a way which actually delivers the funding and accountability for public money that is needed and provides what voters have said they wanted, whilst at the same time not micromanaging and fiddling and moving the pendulum, the policy pendulum, on a sort of quite frequent and regular basis. Now, coming into government, and the challenges that the new administration will face are huge. The danger will be you get sunk very quickly on trying to deliver a longer term agenda, because you will basically, there'll be so many problems coming in, and Tim's worked in the department. There'll be civil servants desperate to get in the door for things to get signed off, and that will quite quickly consume you. The skill will be, can you set the Department of Health up to do both? Can you get the Department of Health to do the immediate short term, we've got to get a grip on the system, whilst at the same time creating enough political space to build a longer term plan which can get the sector, the stakeholder buy-in, that can give you a trajectory and a longer term ambition, which everyone agrees you need in order to deliver on some of the, quite frankly, structural challenges that the system faces. And the real difficulty is whether you have the space, capacity and capability to do both of those things post the general election. And I sort of there was a question that came through in the chat from Nick Kirby. And Nick, it's great to hear from you. Say, do we need a sort of Wanless style? For those who may be familiar, Derek Wanless ran a review of health funding in 2001, 2002, where basically the decision was taken by New Labour to invest more money in the NHS to deliver a set of improvements. My view would be, and this plays back to Tim's point on transparency, is one of the things the new government could do, it would need to do it quite quickly, is to build a baseline of where we are. How is this system actually doing? What is the truth? And what does it actually look like? I would be looking at the chief medical officer and people like the OBR to say, give me a baseline, and then let's work up a plan from the baseline. And you can see the first 6 months of a new government saying, right, we've got to manage winter. We've got to make sure patients are getting the care, as much care as they need, whilst at the same time building out this longer term plan and building out a baseline which we can actually use to then deliver a sort of 5 or 10 year spending settlement. So Ruth, that's a kind of reflection on what might happen in the next 5-6 weeks and what then probably happens in the next 6 to 8 months. But that doing the 6 to 8 month thing is really hard given how challenging things are. So it's a bit of a fantasy plan perhaps, but hopefully helpful to set up the rest of the conversation politically.
Thank you. Thanks so much. Really interesting stuff. I was really struck when going through the report and reading people's responses about the sort of wariness and the feeling that there's lack of transparency, lack of trust. And I just was going to turn back to Kate and ask, in terms of the kind of other work that Ipsos have done, is this sort of typical of faith in other sectors, or does this feel kind of more intense right now in the NHS, particularly in relation to what politicians say and what actually happens?
So I think what we're seeing at the moment are just extremely high levels of dissatisfaction with public services as a whole. It's something like 3/4 of the public think that services have got worse over the last year. That's happened consistently over years now, and they've got very little optimism that things are going to change in the future. I think the NHS almost exemplifies those views on public services as a whole. So it's the totemic example of a public service, which means that the views people hold about it are particularly strong, especially given this commitment they've got to it as a principle, as part of our kind of identity.
Thanks, Tim. Any perspectives from listening as you were in the room with people about how intensely that was being felt?
I think it comes through very strongly, Ruth. It was, you know, we did not have to do much prompting. We basically started these workshops by saying to people, what's your view on the NHS? What's going wrong with it? What's caused it? And that it flowed out quite easily from most people. So, you know, we didn't have to do much prompting on that. It was clear. When we had given them a little bit more information, having actually thought, look, people are talking about some of this stuff already: money, staffing gaps, aging population, growing demand. Actually, we thought we're telling them what they already know, but actually we're then quite surprised that people were visibly shocked. They were quite angry in some cases. So I think they do feel that very, very strongly. So yeah, I think it came through very, very loud and clear.
Really interesting. So we've had a few questions about one of the ideas towards the end of the presentation about, you know, what people wanting more independence. What would an independent NHS look like? What would an independent commission do? Can you say more, Tim, about what you made of those remarks? And in a way, you know, you, like as Richard's just said, we on one level we sort of have that. You have an independent NHS England board, but I guess that sort of level of detail people just didn't really know about. They're thinking about something else, I guess.
I think that's absolutely right. So this was the last session of our weekend workshops, but it came up almost right from the very start when you're thinking about what has caused the problems with the health service right now. And a lot of it comes back to government decision making, how government sort of effectively directs the health service, perception that there's just lots of short-termism that is holding the health service back and meaning that budgets aren't very well spent. So it certainly wasn't, people certainly weren't having in mind the Andrew Lansley model of a a separate NHS England. Definitely not. And we're slightly surprised to hear that it had been given that independence a decade ago. So I mean, it came up everywhere. So when we were talking about options for taxation, one of the things that attracted people to having an additional tax that was earmarked for the NHS is because they didn't completely trust politicians to pass on the extra revenue to the health service. When we talked about alternative models, one of the things that really attracted people to social health insurance was a perception that the funding and the management of health services in those countries, in those systems, are more independent from government, even though actually we all know the truth is far more mixed, and social health insurance systems tend to be increasingly propped up by more and more tax. So I think by the time we got to that point, that sort of independence thing was really coming through. And I think it was partly what, as Richard was saying, it's not about just hand over, the hundreds of billions of pounds that we put into the health service into unelected bureaucrats. They weren't hugely keen on the unelected bureaucrats either. I think it was just trying to find a way of giving it a bit more freedom and protection from some of the day-to-day politicking.
Really helpful. On the international point, Kate, I just wanted to ask if you may not know this, but whether there's any evidence of sort of trust in health systems from international work. And then Richard, I think you know a little bit about the kind of how some of the social health insurance systems work and whether politics really does stay out of them. But Kate first.
Don't so much have information on trust in different healthcare systems. We run a global survey called What Worries the World, where we ask, what are you most worried about? And in the UK, the healthcare system comes up top in that list of worries. Compared to the global average, we're more worried about it than other countries are, but we aren't unique in that. So we're not the only people that are worried. We're just more worried than the global average. So there is something for me about the NHS being special to us that means our concerns about it increase, although actually our concerns are quite in line with concerns in other countries. So, for example, there not being enough staff, waiting lists being too long is very common across the globe. We're not special in that way.
Thanks. And Richard, we've had a few comments, people pointing to, well, I mean, nobody's asking for an American system and saying that's bad, but actually there is still an allure to some of the European social health insurance systems as being attractive. And as we heard, being seen as independent from government in a way. What's your perspective on this?
So I don't see any, I think the message loud and clear from the research is that there's strong support for the NHS model, which reflects, broad polling, full stop. I think the interesting question here is what happens, and Paul Corrigan, former Labour advisor, and Isabel Harman from The Spectator have written about this, which is what happens in 5 years' time if things don't get any better, and what do those numbers then subsequently start to look like? Because it's one thing saying we've had a Conservative government for 14 years, we've had lower than inflationary spending on health and the NHS, we've also had wider cuts to public services. If Labour is not able to then turn things around or demonstrate that they are turning things around, will confidence in the model then start to drop? Because if neither the Conservative Party or the Labour Party, the two main governing parties of the country, can't do it, then who can? And that then opens up a sort of channel of, well, what would an alternative... So you might see more noises off about what alternative systems are. Now, if you go back to 1997, when Labour won a substantial majority, of course, the Conservative Party tilted much more further to the right, and there was active work going on about what sort of other systems and models would look like. And you might remember in the late 90s, actually, there were some big parliamentary debates. There was talk of patient passports, cuts to private health insurance and other things as ways for people to access healthcare that were being put forward. And that's when you got to the 2000 Breakfast with Frost moment with Tony Blair, and then you get to the Wilderness Review, and then you get to the tax increase that pays for it. So I don't think we're in a position where we are, and frankly, we can't move to another system right now. We have not got the capacity or the funding to do it because it will cost a significant amount of money. And restructuring, if restructuring the NHS was the solution to the problem, we'd have fixed the problem. We've restructured loads. That's not the issue. The issue here is about how, as Tim's and the research says, is how do you get a better system? And what have we learned from the last 14 years about what doesn't work? And how do we then set ourselves up for greater success in the future? But the debate on the models, Ruth, isn't done. It never is, but I see there will be big question marks about that at the next election if the politics looks in a certain way and the system doesn't necessarily demonstrate improvement. Public expectations are going, they want to access healthcare. If that's going to still be more difficult in 5 years' time, we might find support for the model has fallen further.
Thank you. And another thing that struck me, Tim, it would be good to hear your reflections on, and Kate from in the room, was there was very little support for charging for services. And yet this does pop up quite a lot, doesn't it, in the media amongst, certain people could have, and it looks as though it's an attractive policy, and it's sometimes held up as part of a waste thing. People wouldn't waste appointments if they were being charged from them, but that got short shrift. Tim, what did you learn from that?
What did we learn from it? So yeah, I mean, I think it keeps coming up because there is a superficial attraction to the idea of it's adding more money into the system, and it's also trying to promote people making more responsible use of a public service. But bringing in some examples and some evidence about other areas of where we charge in the health service already. So, for example, with prescriptions, I think it rapidly became clear that there would, you probably wouldn't raise very much money at all, because any sort of reasonable attempt to try and do this sort of policy, you'd probably make the vast majority of people exempt, or the vast majority of people who need services exempt. And so you probably wouldn't raise anything, and people quickly tumbled onto that. So on NHS prescriptions, for example, 9 in 10 items are dispensed for free. So the sort of revenue raising attraction quickly goes away. But then also there's evidence that, yeah, charging would deter people from making unnecessary use of healthcare services. But it's also clear it would deter people from making necessary use of services. And I think people very quickly got the idea that if you charge for one bit of the service, then you might simply push problems down the road, or push people into services that are free to the individual, but actually much more expensive to the taxpayer. You might also expect more health problems to result from that. And the one area, and Kate might want to expand on this a little bit more, the one area where people did, I think, hang on to the idea of charging a bit more was around missed appointments and this concept of misuse. So Kate, do you want to pick that one up?
Yes, because we didn't go into that in detail, did we? We didn't provide them with the other evidence either way, but they definitely leaned on, okay, not charging, but perhaps charging for missed appointments. And that feeds into this feeling that there are many people in the public who abuse the NHS. And the frequent example is people not turning up to appointments, or people going to A&E when they should just see their GP, which I think are things that they read about in the media quite likely. So the missed appointment charges is very much linked to that feeling that some people in the public, obviously not themselves, never, but some people in the public abuse the NHS, and they want to stop that from happening in order to save money.
Really helpful. I was thinking a little bit about what you would say from Kate and Tim about, and I'll get Richard to comment on this in a minute, from your experience of being in the room with these groups for the time that you did. What sort of signals would they need to see that the NHS was improving? I mean, we know from all the work that we've done, this is going to be a long time to turn around. It's the NHS has massive challenges. There isn't a lot of investment ready to go in. People really want it to succeed, but they're also wary of waste. They're wary of things not happening in the way that politicians set it out. So what sort of things would convince them that the NHS was getting better, do you think? Kate first.
So their biggest worry is around access. I've seen a question in the Q&A as well, that experiences in terms of quality are still holding up pretty well. Once people actually use a service, they're very positive about it on the whole. It's access that people are most worried about. So that's the one thing that they would need to see to be convinced that the NHS is improving. Now, obviously these issues are going to take a long time to address. If you think about GP services in particular, you have, I don't know, 7 in 10 people use those services every year. So that's the front, people describe it as the front door of the NHS, the part they have to go through to get to the other parts of the NHS. And so I think a focus on that would be the quickest way of being able to show people that improvements are being made. If they're
And was
able
that
to
very
get
present
door.
in the room, difficulties with general practice?
So present in the room. And again, it always has been thus. A lot of these things we have heard over the years, but it's just such a strongly held view now. And that's one of the first things that people in any qualitative research will talk about, is how hard it is to get an appointment. You have to call at 8 a.m. and you're on hold. So many people have these stories and are feeling very frustrated about it.
Tim, what would you say were the signals that might convince people that things were shifting?
Well, I'd agree with Kate. I mean, purely on a numbers point and people actually having direct experience of the health service, over 350 million GP appointments per year versus 24 million A&E visits. So people are much more likely to come into that direct contact with the NHS through that route. I mean, beyond that, I think we come back to a couple of the themes that were raised throughout. So one being this idea of waste, and actually that is something, there are aspects of that could be addressed relatively quickly. So improving administration, improving communication. It's a real shame that Louise Ansari is not able to be here, because Health Watch England has done some really interesting work to really explore and draw some of those things out. The second thing is improving staff experience, and if you've got a service that works better for people when they use it, and a service that seems to make staff a bit happier, then those should be signs that things are heading in the right direction.
Richard, your thoughts on learning from that, what should be top of the list? Should it be general practice access, perhaps even outweighing what we're hearing about the millions on a waiting list?
Yeah, I think it's really interesting, isn't it? Because you've got both political parties. One has had a commitment to cut waiting lists, and if you're looking at Keir Starmer's pledge card, it's cut waiting times. It's very similar, slight difference in nuance, but the focus very much, although you could say cut waiting times, could be to see a GP. The feeling is that it's very much directed at secondary care more than it is at primary care. Now, when the long-term plan was written, obviously not 2018, 2019, the ambitions within that sort of were reflective of the fact that people wanted to see this shift of more care going into the community and the overall pie, greater funding going in. I mean, I think the thing that no one's yet come up with is a credible primary care plan. We've had, access targets and all the rest of it, but the thing that I think is going to be very much front of mind for the next government is, what does a proper primary care and community care plan look like? We've got a cohort of GPs who are nearing retirement. We have significant pressures on that system already. That really does need to be right near the top list, and the public is, as you can see that, because they go through that system and they go through it on a regular basis. Now, what does an improvement look like? Well, an improvement probably looks like how you access the GP in terms of contact, and there is work that's already going on elements of that, and then it's how quickly do I get seen, and on both of those metrics you'd want to see some level of improvement. There's lots of excitement obviously around digital. That will work for some, it won't work for everyone, but yeah, routes through that primary care system are critical. But then, Ruth, even if you got that working, if you've got a bunged up secondary care system, your waiting lists are just going to go up, right? So I think, again, one of the things we need to sort of take a step back, this is why we've got to do the short-term, long-term thing, is the learning here is, if you protect the NHS revenue budget and you cut the coterminous budgets of capital, social care, public health, local government, the system was not going to be able to cope. So how do you build, and one of the things I'm sort of looking at the moment is, do we need another NHS plan, or do we need a health plan? And it feels to me like you want, and to say to the public you've got an NHS plan, but if you only have a plan that is around the NHS, you're probably starting from the wrong place. You probably need to start from the wider lens and work out how your NHS system fits in, rather than starting on the terrain of a new 10-year NHS plan. So some considerations, I think, that need to be sort of fully thought through on elements of that.
Thank you. Thinking a bit about the process here, I was really struck kind of reading and listening to the outputs about, you know, the value of doing work like this that gives people time and space to discuss things, has things explained, and people can, you know, have time to think about it, as being a way of also shifting people's views on things. And you know, there have been comments coming through, you know, about citizens, juries, and other ways of sort of public participation being built into the system a bit more. We have, you know, examples of that at various points in the system, but it's not a straightforward thing to do, is it? Turning to Tim first, I mean, there have been in some of the sort of, you know, the long-term plan, the NHS plan at national level for Our Care, Our Say in the mid-2000s, there have been big efforts, haven't there, to involve the public, but it's not a straightforward thing to do. And it's also quite expensive, what we've learned too.
Yeah, I think that's right. And I think it's particularly timely given that we've got, you know, there's talk of Sue Gray, Keir Starmer's chief of staff, thinking about how a Labour government might use citizens' juries, citizens' assemblies to involve the public more in policy making. So how might that be applied to development of a new NHS plan or a broader health plan, which sounds like a fantastic idea. But yeah, it's hard work. It takes up a lot of time and a lot of energy. It's not cheap. We did what felt like a really big project, and we're still talking about what, just under 75 people who we are able to take through that process. So being able to do that from a national perspective is really hard. Being able to having to do that following an election when the winning side will have made various manifesto promises. I mean, in some ways, doing this as an independent charity was quite a lot easier because we're not having to make those choices. But there are some tricky bits to think about. How do you properly frame meaningful choices that people can make where those choices can be made to matter? Because actually there's no, if you're going to do this kind of exercise and say, tell us what you think is important and what you want us to look at, and then disagree with people, then it's probably worse than pointless. So actually framing some you know, a set of choices that you are happy to accept that don't conflict with your manifesto is really, really hard, I think, to do. I think one of the other key decisions that any work like this needs to bring in is, are you asking people what they think and what's important to them, or are you asking them to make decisions? Because you might design this in quite a different way, and it might have implications for what you do. So I think if any party, any future government is looking to make use of this, and it was an absolutely fascinating, really energizing process to go through. It was also a lot of work and it was knackering. I think you've got to think very carefully about what you engage people on and how you do that really well. And also, I think critically, how you really tie that in and make it central to your policy making process rather than just as an add-on.
Thanks, Tim. Kate, any perspectives on this? Because obviously you must have worked with lots of different kinds of organisations, some of them, you know, not just independent charities like ourselves.
Yeah, Tim is absolutely right. The key is to be picking a policy or a decision where these types of approaches will work. You're not just finding out what people think and it's not a giant focus group to find out what people think. It's actually putting a decision or a policy to people. So it will work for some issues better than other issues. And you also have to think about what's the outcome that you want. So this is one particular approach. There's another approach where you might work up with your participants, like principles. So when you're designing services, what are the principles that should be adhered to? Or in other projects, we work with ICHP quite a lot, where we've developed recommendations off the back of these types of work for, you know, how health and care data, for example, should be used. There's lots of different ways of using it, but you have to be careful to select the right issue. It's also very helpful for seeing what's the information that's fed in that has changed people's views that they've really seized on. And that can then help you with communications more generally. But I also think it's worth noting that this is always going to be with a specific group of people to help make a specific decision. It's not going to reach, you can't do this with 60 million people, although Tim and I did briefly think about going out and trying that. You can't reach 60 million people through doing it. So you also have to think about the comms. And I was struck, for example, that there was very little recognition that the NHS had ever done any 5-year forward view or long-term planning. And that just really struck me, that despite all of everything you hear in the kind of policy circles, that doesn't even reach out to the public more generally.
Thanks. Really interesting, Kate. And Richard, I mean, someone's just put in the chat here that most public engagement is very paternalistic, and I can see why they might think that. I mean, despite the best efforts of us, I'm sure we were trying to be the opposite of paternalistic, but I can see how it might get perceived as that. Is there a point in doing this at a national level, particularly around a sort of, building it, if a new government comes in, wants to build an NHS plan, or is this ultimately more meaningful to be done at a more local level, at the integrated care board or local government, where it has more traction and a sort of more of a focus potentially?
I think you need to do both, Ruth, in both cases. I think the trade-offs and decisions that the next government will have to take on health and social care are really, really tough, and they will require political leadership in order to make those choices and to bring people with them. And in order to do that, you will need some kind of national level approach. Now, from the Labour perspective, they're talking about this health mission and a sort of approach which is above the Department of Health, which is more cross-government, which is, trying to take a more long-term view. Within that health mission, you could see quite a interesting approach for engaging with the public. But if you just do it at that national level, you will completely miss, first of all, a whole section of people who won't necessarily engage with that. But also, as we saw through things like the COVID vaccine program, some of the most effective engagement was done at the most local level, where people understand their communities and understand the differences and nuances that go into community engagement, which is, as has been proven from this research, takes an awful lot of time to get right and needs to be properly managed. So I think you need to do both. Obviously, that has resource and time implications from doing that. But unless you do both, you won't be able to bring the public with you for making some of the tough choices and trade-offs. Then, as a politician, you won't make the tough choices and trade-offs, and then you won't make any progress. So, and we can't, as we know, we can't stand still here. So we're going to have to make some choices. So you will need that high-level political leadership, but then you also need to empower those local areas and local communities to run locally led exercises as well on, what a better future health and care system looks like and what the trade-offs are.
Thank you. I'm struck by that the issue of privatization's popped up in the chat quite a lot, mostly worries about the private sector taking more of a share of activity. I just wondered, Tim and Kate, how much this was a sensitive issue in the actual sessions themselves. Tim first.
It certainly came up. It wasn't a major issue that we set out to explore. I mean, it came up in a number of different ways. So I think certainly for some people, when we looked at sort of whether we focus more on primary care or hospitals, I think one of the factors that made people a bit more reticent around focusing much more on primary care was the fact that the status of general practice as independent small businesses that are working on contract, some of the perceptions and misperceptions around how much GPs get paid, things like that. So it came up through that. I think there was it also partly fed into conversations around the NHS model as a model free at point of use, and it's sort of questions around people being able to go private, being encouraged to go private. Does that undermine the integrity of the model, and where do we take it from there? We did do a little bit of probing people on it when we were talking about alternatives to the health service. Although we looked mainly at social health insurance and introducing additional charges, we did also give people a little bit of information about what does a private health insurance model look like. And it became very clear very quickly when we did so that people were not at all keen on that. There were lots of concerns around equity, fairness, cost, whether services will be as good as we could expect from the health service in many ways. So it provoked some quite strong feelings, but Kate may want to add some more.
I think you've covered it all there, Tim. That's what 3 weekends will do.
Brilliant. Well, we are getting towards the end, and I just would like to hear some reflections from all three of you. It's been a fascinating discussion. I mean, if this doesn't feel like a kind of unfair question, but whether, you know, what one element of the research would you want those about to hit the campaign trail to bear in mind when they're talking about the NHS, from what you heard from people? Kate?
That's quite a big question, really. I think what we should take from it is this ongoing commitment to the NHS as a model, but it has to work better for people because they're not happy with the services it's providing at the moment. So that needs to be the focus, is how to make it better for the people on the ground. And I will include in that the staff, because they are absolutely critical to getting this right, and they're critical to the public's belief in the system.
Thank you. Tim?
Still scrabbling to get my thoughts together. What would I take? So I think it's that actually engaging people in some of these difficult decisions is incredibly valuable. One of the things that I was really struck by was we did manage to quite quickly get people really immersed in some of the details and the difficulties and the pros and cons of the decisions they were making, and they see that this stuff is really hard. You know, I think there's a quote in the report about, you know, I can't decide what to do. There's just no good option, which was kind of the point. So I think the thing I'd take off is that there are no easy options. There are no good options. We just got to kind of make some tough decisions, but there is potentially backing out there for doing broadly the right ones.
Thank you. Richard, what would you take from it and passively pass into the ears of those about to campaign now?
Yeah, Tim made me smile when he said there are no good options. That sounds like some of my meetings in government. So I was reminiscing there. I think trust is low. It is a really important thing that's come back, and some of that is to do with the politicians' role in the health service, but also just in politics more generally. And I think one of the themes that comes out quite clearly, and it sort of builds off what Tim just said actually, is be open and transparent with the scale of the challenge that exists and what the art of the possible is and what the choices are. If you start from that basis, I think people will give you at least a fair hearing. They might not agree with the choice that you end up taking, but they will at least understand what the options are, what the choices are. And then from a sort of more policy lens, I think there needs to be a real focus on that primary care system and what is going to happen with it, and where it goes next, and that cannot be a sort of add-on to, you know, a sort of hospital focus, and I think that comes out through loud and clearly in the research.
Thanks so much. I'm going to draw things to a close. I just wanted to draw your attention to the fact that on our website there's lots of more information about this. So there's the full research findings on the website, and the video as well. You'll also find the kind of full report that Ipsos has done, including, for transparency purposes, all the material we used in the sessions as well, so you can see what information we gave people. And we'll also be conducting more polling, Tim, won't we? We've got more public polling to look out for, so look out for that too. But this has been a really fascinating discussion and a good way of sort of, you know, focusing people's minds on the next 6 weeks. We're going to hear lots more about this. But thank you so much. And I just want to thank our participants. So big thank you to Kate Duxbury, Tim Gardner and Richard Sloggett, and of course you, the audience. And there's been hundreds, literally hundreds of questions. And I'm sorry we haven't been able to answer any more than a fraction, but really appreciate your energy, and please check on our website. So thank you so much, all of you. Goodbye.